Thank you for all coming back for the last talk of the day. I don't know if many of you know Professor Dark. Professor Dark's a very well-known pioneering surgeon from Newcastle. He's just retired last year from clinical practice, but really put Newcastle on the map for heart and lung transplant, and over the last 30 years. And a few of the big achievements under his leadership: Newcastle first successful infant transplant 1987, first single lung transplant in the UK successful 1987, first double lung, UK and Europe 1990, and first non-bleeding DCD lung transplant in the UK in 2002. So he's been behind heart and lung transplant for the last 30 years, and it's been an honour to have him here to speak on lung transplant.
Thank you.
Thank you.
Thank you very much. It's a huge pleasure to be back here. I spent 5 years in Glasgow in the west of Scotland as a junior registrar, subsequently Cardiothoracic Surgery Registrar at the Western and the Royal and Sick Kids. There are one or two familiar faces in the room, but it's great to be back here. And thank you for staying on after coffee on a Friday afternoon when you could be getting off and doing things. I've been given this remit of the whole of lung transplantation, and believe you me, I am not going to cover all that. I'm just going to tell you one or two bits and pieces and speculate about where we're going to go in the future. So we'll see if this works. I get research support from a company called vivo. I spent 24 hours as a consultant for Transmedics before I told them that I didn't think their device was any good for the lung, and they fired me. And the device is actually quite good. So I was wrong, and they were right. I worked for 30 years at the Freeman Hospital, having also been a consultant in Edinburgh. So I've got lots of Scottish connections. The Freeman looked like that when I moved there. It now looks like that. It's got vast numbers of buildings everywhere. And in particular, we built this thing, which is a transplant institute. We have heart, lung, liver, kidney, pancreas, all in one site. We have a single ward where we look after, except for the kidneys, all of the other solid organ transplants. And there's been a lot of interaction between the various groups. It's been a very exciting time to be there. So just a little bit more background, because this allows me to introduce the Scottish link. We started transplants back in 1985. That's our total number. We primarily did hearts to begin with, and it frightens me that we were doing 50 and 60 hearts a year when there were only two surgeons. And Alan Kirk was the retrieval surgeon who looked after everybody all the time as well. Ian Colquhoun followed him. So we've got lots of good Scottish links. And then we did more and more lung transplants. More recently, we've done a few hearts because we also have a paediatric heart transplant program, and we have a VAD program, although I wasn't personally involved in that. And we started off doing lots of single lung transplants, and then we moved to the bilateral lung. And as you can see from this graph, most of the transplants we do now in the pale blue are bilateral lung, which I think is a bit of a pity, because the single lung is a good operation for the right recipient. This is a picture of dividing the donor pulmonary artery into two halves. You've got two good organs there. It provides the greatest benefit for the most. It's a good socialist operation, which is why this man ended up as our longest single lung transplant survivor. Sam Galbraith was a neurosurgeon here in this city. I was his registrar in 1980. He went on to get pulmonary fibrosis. He lived for 24 years. After a single lung transplant, he became an MP, and I think he was Minister for Health in Scotland. A wonderful demonstration of what you can achieve with a single lung transplant. And another indication of the links between Newcastle and Scotland, because we've had the contract for doing Scottish lung transplants, and this shows you our activity. The Scottish patients are in the red, and we've actually done an awful lot. You've had a higher proportion per head of population of lung transplants for Scotland done at the Freeman than is the case for the UK as a whole. I think that's because you've got a very centralised service. Your cystic fibrosis service, for instance, is nationally is nationally funded and organised, and because we developed these very close links, so we got lots of referrals. And I would have to say that having dealt with lots of commissioners, the Scottish commissioners, oh, there's one sat on the back row. The Scottish commissioners were the best and most professional commissioners we ever worked in. I had to say that, Anish. So you're wonderful people. Okay, right. Let's look at a more general thing. This was a report looking at increasing numbers of organ donors. It came out 10 years ago. So now we've got 10 years of results. We've increased organ donation over that period quite spectacularly. To begin with, the increase was in DCD donors, but gratifyingly, more recently, we've put up the numbers in DBD donors. We can speculate about where this is going, but NHSBT gave me these slides, and they're really quite optimistic about what the numbers are going to do in the future. There might be 40 or 50 more hearts and lungs. There's another change on the horizon, and that's presumed consent. But there's been a lot of speculation at NHSBT, for whom I work a little bit, about what we're going to achieve with the opt-out legislation. If there's minimal impact, the increase will be small. We actually think it might be significantly more than that, and it could have a high impact. We could do another 50 or even 100 hearts and lungs as a result of this change in legislation. I have to say the initial experience in Wales has not been as positive as that, but let's be optimistic. It's clearly going to happen in Scotland. It's pretty much almost certainly going to happen in England. Not that anything else except a word we're not allowed to mention is ever talked about in English politics, but I think it really is going to happen. That's transplantation as a whole. Let me talk a little bit about just the lung. This is lung transplant activity and the lung transplant waiting list over the last 10 years. And the waiting list is going up, and that's happening everywhere. The activity is fluctuating and a little bit unsatisfactory. We had a peak 4 or 5 years ago, and this probably coincided with the introduction of ex vivo lung perfusion. I'm going to talk quite a lot about that, as much because you went to look at some more marginal lungs and ended up bringing them back for transplant, as we actually got lungs from the EVLP process itself. And then it fell away a bit for reasons that aren't very, very obvious. There was another peak last year, and this was almost certainly related to the introduction of an urgent category, and people appreciating that the really sick patients for whom we were getting recipient-specific offers, we could say yes to with those slightly dodgy lungs because we'd identified them as sick. And unfortunately, that's not been sustained. I'll show you some other figures in a minute. But by international terms, we're still doing very badly. These are European total donor numbers. We're standing at 21 in the UK, 40-something, 43 in Spain. The other total number of donors were not too far adrift, but look at where we are for the thoracic donors and the thoracic transplants. This is heart transplant numbers, 3.2 per million. France is doing more than double that. Even Germany, where transplantation has been beset by all sorts of scandals, is doing better than us. Austria, twice as good as us. And it's the same for the lung. We're lagging behind, 2.6, half of what they're doing in France. I highlight that 2.6 figure because, of course, the figure for Scotland, with the Freeman Hospital doing the transplants, is over 3. Just thought I'd emphasise that to you. This year is bad news for lung transplants, and we don't quite know why. This is the total number of organ donors in the UK, which has gone up, brain-dead donors, which has gone up this year. This is lung transplant numbers, which are down, and it's down at every centre, and we don't quite understand this. It's gone back to where it was a couple of years ago, after last year was a particularly good year, and it's being looked at with considerable concern by NHS Blood and Transplant. What does this mean for the patients? Well, this is analogous to some of the pictures that Simon showed. These are all the different organ types, and you see the lung has the biggest category of died on the waiting list or removed, and that's just after 1 year. And if you look at the figures after 3 years, you'll see that a third of our patients have either died or been removed from the waiting list. And we've only transplanted 2/3 of them. These are people who are desperately breathless, too breathless, a bit like me standing on this stage to put one word in front of another, living miserably for years before they get their transplant, and a third of them are dying. So the message is we need more transplants. How do we get these? And that's what I'm going to really devote the rest of my talk to, because it's looking to the future. I've told you the current state of play. It's looking to the future. They're clearly there. This is a breakdown of what happens to the potential donors that are offered and what happens at each stage. And you can see that for DBD lungs, we're down to using about 20% of the potential, whereas liver and kidney is up at 80 and 90%. And for DCD, it's even worse. It's only 6%. That is better than the 2% in the US, but still has a long way to go. And it's important because DCD donors, as you've heard from other speakers, now comprise 40% of all our cadaveric donors. So they're a very important resource. And I won't show you the slides, but essentially the outcomes for lung transplants from DCD donors are every bit as good as the outcomes for DBD donors. The trouble is we exclude 94% of the potential lungs for a whole variety of reasons, including the fact that we can't assess them properly. Why is this decision-making not better? What are we doing wrong in selecting these donors? Why are we not using more of these donors? And one of the reasons is that the criteria for good donors are badly defined. This is a slide from about 10 years ago of the ideal donor. And actually, the figures are plucked out of nowhere at all. We say good gases, PO2. People put a lot of value on the PO2. It's a classic example of putting value on something you can measure easily without looking into, does it really make any difference? And this next slide is one of my favourite slides. I try to show this in every single talk I give. If I was giving a discussion about town planning, I'd probably try and show this slide. Essentially because, and this is UNOS data, 12,000 lung donors in the US, all used for transplant, divided into groups as to how good the blood gas was on first referral. Now, we put great weight on blood gas. This says it doesn't make the least bit difference. It's not in itself a reason for accepting or turning it down. And the actual blood gas at the time you offered the donor is absolutely not a predictor of how good the lung will be. No difference in early or median survival for any of the groups. Donor PO2 levels did not affect graft survival. If we go around thinking it's important, tell us what the PO2 is. Repeat the gases for me. Lots of things like that. Smoking, this isn't a bit of an aside, smoking is important. And we did a lovely study, and it's an example of why good studies can be done in the UK because we've got complete data collection. This is the effect of smoking or non-smoking on outcomes after lung transplant in about 1,200 patients. We published it in Lancet in 2012. It's clearly worse if you have a smoking donor. It's even worse if you have a heavy smoking donor. The really clever bit about this paper was that we calculated the outcome for patients who turned down a smoking donor and waited for a non-smoking donor. And because 40% of the donors we use in the UK, the actual using smoking donors on the red had a better outcome than waiting for a non-smoking donor if you were a lung transplant recipient on the waiting list, which I think is a really elegant thing. So, there are lots of things happening in our donors. We have all these things on the left-hand side that happen to anybody on a ventilator. In addition, we have at the bottom right-hand corner the sequelae of brainstem death. And it's become increasingly obvious that brain death is bad for you, and it's bad for the organs you're going to donate. And we spent years blowing up balloons in the skulls of rats to show this. But for instance, this is what happens to your capillary endothelial membrane in the lung in a brain-dead donor, brain-dead rat. The control rat has got a completely normal level. There's a massive release of pro-inflammatory cytokines. The particular one we look at is this one on the left, IL-8. Now, IL-8 goes up whenever you're sick. The levels in the yellow are levels we measured in brain-dead donors that were subsequently used for transplant. These are the sort of levels you see in somebody with, for instance, acute pancreatitis who's already on a ventilator with ARDS. And yet they're in the lungs we're going to use for transplant. And they correlate with outcome. This is I don't know. Yeah, this is early graft function correlated with IL-8 level. It's a really good correlate, and we found this in Newcastle. It's been found in other centres around the world. However, and of course the assay was done after the transplant, if we looked at the levels in the lungs that were actually used, we see that, of course, the donors we used had better PO2s, because we all thought PO2 was important. They actually had higher IL-8s if we used them than if we didn't use them. And IL-8 really does have a determinant of how good your survival is. All this is saying is that the clinical assessment of the lung is not very good, and the physiological things we measure are not particularly reliable. So, we turn down lots of lung transplants because surgeons are badly educated. They don't think about what they're looking at. The assessment of the DCD lung, where there's no circulation, you can't do a blood gas, is even more difficult. All lungs have got an injury, whether it's DCD or DBD. Good donor management is important, and that's something we're trying to improve through NHSBT. And there may be a role for ex vivo techniques. This is the overall picture. There's lung injury, which comes from brain death, it comes from ischemia reperfusion injury, and then reflects in primary graft dysfunction. Early dysfunction costs you in terms of resource, longer ITU stay, longer time on a ventilator, but it reflects in worse long-term outcome. If you put in a damaged lung, you struggle early on, and your long-term outcome for those who've survived 1 month, 90 days, or even 1 year is less good. So it's really important that we try and reduce this lung injury. Which is where I come to this man. This is a guy called Stig Steen. Only in Sweden would you wear a sweater like that on your laboratory photograph. Stig's a really imaginative, innovative cardiac surgeon who's made a mark both in lung transplantation and in, I hope in the future, in cardiac transplantation. And he had the problem of how do we assess the DCD lung? This is what the lungs look like when you've taken them out. And you've got your retrieval surgeon saying, well, they're kind of nice. You know, they're inflated, they're not too heavy. I think they're okay. It's all very subjective. And Stig Steen said, can we get objective measurements here? And he wrote a paper in Lancet now 17 years ago describing the first use of ex vivo lung perfusion for lungs from it was actually an uncontrolled DCD donor. And his basic system was this. He simulated the circulation. He actually used the heart as a means of cannulating the lungs, but basically you push blood or fluid through the lungs, you ventilate them, and you measure what comes out. And you simulate the clinical setting. You simulate reperfusion, in fact. It allows you to gradually rewarm the lungs. You can control the pressure at which you reperfuse them. You can spend as long as you want doing the bronchoscopy. You can recruit them, but you then adopt a lung protective ventilation. And then you can do a series of assessments, physiological assessments, when you can look at the lung in their entirety. And if you want to go on and transplant, you cool them down. You've got a hyperosmolar perfusate. You filter out all of the white cells, and we know that the cytokines, the IL-8, are driving the white cells to stick to the endothelium and then go through the endothelium. You can give steroids, maybe other anti-inflammatory drugs, and you can give antibiotics. And then you can assess the lung. You can measure its PO2, you can measure its compliance, you can measure a whole load of potential things. The benefits are that you can assess the lung objectively. You can potentially recondition it, and I'll discuss a little bit about that. You certainly you certainly take ischemic time out of your calculation so you can improve your logistics and potentially do all of your lung transplants in daytime. Although I can tell you as a team manager, it makes you more enemies than friends doing lungs in daytime and messing up somebody else's theatre list. But it has attractions. And the lung is particularly suitable for this approach, partly because cardiac surgeons, for us, perfusion is second nature. We know the mechanics of it. It's stock in trade. And partly because the lung's got two means of delivering interventions. You can put them into the blood. You can put them into the airway. So we're trying to do all sorts of things. I'll go through this fairly quickly. We can get rid of infection, perhaps. We can minimize the effects of brain death by damping down that inflammatory insult, letting the hydrostatic insult get better. The ischemia, I've said we can get around, and EVLP is ideal reperfusion. It's controlled pressure, it's at the right temperature, there are no white cells in it. It ought to be ideal. This is what it looks like in practice. We take the lungs out, we take them back to the Freeman Hospital, we stick them on a perfusion rig, and it's very simple plumbing. There's no big rocket science about this. And then we assess them. And that's a picture of me peering down a bronchoscope of the lung on our rig. We actually did this in an ITU cubicle, but we've now got a perfusion room adjacent to our theatres. This is what the circuit looks like. You blow blood into the pulmonary artery, you let it out of the left atrium, you have a pump, you have an oxygenator, not because you need to add oxygen, because you're ventilating the lungs at the top, but because you want to deoxygenate that blood so you can measure gas transfer. You want to effectively provide it with mixed venous blood. You can have an open atrium like that, or you can have the Toronto system, which I think is probably physiologically superior, of closing the atrium. We can discuss why that's important. And in practical terms, that's the sort of thing you achieve. This is a rather grungy-looking lung. 6 hours later, it's looking like that. It's looking very pretty, and we can confidently transplant it. And there are a variety of platforms. These are the Swedish ones. There's a Dutch one. There's also this very expensive American one. You've heard all about the organ care system before. The lung thing is just as expensive. And I didn't think it was going to be any good, but it has been some good. And we've gradually introduced this technology, initially in London, then in Toronto, then in a whole series of worlds, including a multi-centre study we did in the UK. So I think you've heard all that already, yes. What assessments are you going to make? Well, you can measure PO2. You can measure vascular resistance. You can measure compliance. There are lots of opportunities for intervention, antibiotics, anti-inflammatories. You can do things to the endothelial injury. And there are some nice examples. We showed years ago that infection is bad for you in the lung. Then we wrote a paper showing we can get a 10 log diminution in bacterial load by adding high-dose antibiotics to the EVLP. And we're effectively adding 10 times the dose of meropenem because it's only going round the lung, it's not going round the rest of the body. One of the problems we haven't solved, and this is a rather nice pig model from a group in Hanover, are the properly infected lung. And we don't yet have a solution to that. And we're going to need longer-term perfusion before we can solve that. There's been lots of research done. Rats, pigs, they've used a rather disappointing standard insult, which is not the same as everything the lung donor has gone through. And they've used EVLP as a means of assessing the endpoint, which is not that good. But there are some nice results. You can, for instance, add hydrogen, which is a really interesting gas. I wrote an editorial saying this is more than just inflation. Hydrogen's an anti-inflammatory gas. So you can improve oxygenation, you can improve, what does that say, gases, you can decrease vascular resistance, and crucially, you dramatically reduce the pro-inflammatory cytokines just with hydrogen. IL-8's a favourite of mine, as you will have gathered from some of these slides. You can add other drugs. A beta-adrenergic receptor agonist does the same sort of thing. Alpha-2A receptor agonist does the same. The list is endless. We had a bit of a play with this thing, which is a cytokine-absorbing membrane. You can just plumb it into the circuit. It's probably too late because the lung damage has already occurred, but it's a very nice bit of kit. You can put in mesenchymal stem cells, and there's some fascinating work on that. You can use viral transfection. The IL-10, the Toronto group have used IL-10 upregulation. The Hanover group are silencing MHC expression with a viral vector. It's absolutely fascinating. Unfortunately, I've seen that already. Unfortunately, there are absolutely no clinical studies. Lots of people have used EVLP to assess lungs and perhaps to recondition them. Nobody has yet put into clinical work one of these interventions, despite vast numbers of rat and pig experiments. So in a sense, you still have to believe whatever you're told. And I'm sorry, maybe that's a risque slide to show. You know, we're still left with people saying, this is the greatest thing since sliced bread, and the evidence in clinical setting is lacking. Okay, let me get through this fairly quickly. This is an example of why assessment's not very good. These are lungs that we used or not used after EVLP in Newcastle, and we went on blood gases. And you can see that the green ones got quite a nice improvement, and the red ones, the ones we didn't use, some of them improved quite a lot. It wasn't particularly good. Actually, compliance is better in separating the good lungs from the bad lungs, but it's still not ideal. There's still an overlap. And the physiological measurements are not very good. You can measure lung water. The Toronto people went off and measured endothelium and made a big fuss about it. I show this slide because I was very unimpressed, and I hope you'll be very unimpressed. The amount of separation in those groups is tiny, even though the statistics just about crept into. You would not base your clinical decision-making on that sort of measurement. I show those slides because in Newcastle, we looked at IL-1 beta as a marker, and it was much better. And we looked at lungs that worked after transplant, lungs that didn't work after transplant, and lungs that were discarded. And if you look at that top left graph, the IL-1 beta clearly discriminates the good lungs from the bad lungs. And we got very nice separation of the two groups. And we're currently working with a company that will give us IL-1 beta assay in 25 minutes, which I think might be a big breakthrough. Finally, what about the technology? And one of the problems is that, let me go through this quickly, probably we damage the lung a bit whenever we put it on one of these machines. And we improve it a bit, and the two kind of balance out. And one of the bits of evidence of that is a trial they did in Vienna, where they took standard transplants and randomized them to either EVLP or direct implant. The results for standard lungs were just the same. The EVLP group did not get better. And I've already told you, all of those lungs were a bit injured. And this is saying the EVLP does some good in the really injured lungs because the good overwhelms the bad, but we haven't yet got the technology to make it really work in the standard lungs, even though those lungs are injured. I've told you we've got static EVLP, where you do it back at the recipient centre, or you've got mobile EVLP, this sort of thing. Now, Transmedics tell us that this is great because it takes ischemia out of the equation. It reduces the ischemic time. Is ischemia important for the lung? I don't think so. This is a registry slide showing the effect of ischemia in pulmonary fibrosis patients who are the highest risk patients, and the difference is really very small. It just about creeps into statistical significance in about 6,000 transplants. This is UK data looking at the spread of ischemic time over the years. And you see at the right-hand side, we're getting a bit happier about using lungs with longer ischemic times. We separated out 4 ischemic times by quartiles and plotted their survival, and they're just the same. So within the limits that we're using, ischemia does not seem to be an issue for the lung. So why should that Transmedics machine at 35,000 euros a go make any difference? I don't know. But in the INSPIRE study that was published earlier this year, they had a lower primary graft rate in the study group than in the non-study group. Now, it's difficult to see that that's ischemia alone. So maybe that technology is a bit cleverer than I've been thinking. And me getting fired by the company because I said it was a waste of time is maybe one of the bigger mistakes I ever made, and I should still be a consultant with Transmedics. But it's an example that we're still groping towards the best technology. I'm going to miss out different perfusion, but one appealing thing is negative pressure ventilation. All of us in this room are inflating our lungs by negative pressure. There's lots of evidence that positive pressure from a ventilator is bad. It upregulates those pro-inflammatory cytokines I've been talking about. Why don't we negatively ventilate the lungs on EVLP? Neat idea. Actually, and one of my registrars pulled this out, this is from 1970, and somebody had already thought of it. This is a negative pressure ventilator, actually flow from a donor animal, but it's got a pump in it. There is a group in Canada who've done this, and I think this is really exciting, who've shown that they get less inflammatory upregulation and less lung edema if they negatively ventilate the lungs on EVLP compared with positively ventilating. And I think it's a really exciting prospect. And if I was putting money into something, I would find a venture capital company who wanted to negatively ventilate some lungs. This is what their circuit looks like. It's slightly complicated, but the perfusion bit is just the same as the other ones. The ventilator chamber is different. So, let me wind to a conclusion, because somebody keeps looking at their watch down here. EVLP, I haven't really shown you this, but it is of benefit in some discarded lungs. You can transplant some lungs safely that otherwise you would have turned down for transplant. Or you go and look at lungs that are a bit dodgy and say, well, they're not that bad after all, let's just transplant them. It's essentially if you're going to have an uncontrolled DCD program. That's Maastricht Category 2, where the donor is just wheeled into an emergency room and you've got no past history. The platforms are continuing to evolve and the technology is changing all the time, and I think that will be the really big change. It's a bit like we heard in the first talk this afternoon. The engineers are coming to our rescue. We haven't really defined the best endpoints. We haven't begun to explore the therapeutic interventions that we could do with these lungs sitting there warm, perfused for 12, 24 hours if we want. There's a broader concept here. Organ perfusion, liver, kidney, heart, you've heard a bit about with the DCD, lung, are all benefiting, and the UK is at the leading edge of this. UK is at the leading edge of DCD heart, as you heard. It's probably at the leading edge of normothermic reperfusion, regional perfusion for kidney. And it's important that the transplant community as a whole comes along. And therefore we need to think about how we're going to organise these services. And this really is looking further into the future. We want more organs, we want better organs. Are we going to have every transplant centre doing this? You've already heard Simon Messer's view that DCD heart retrieval is quite skilled, and you don't want somebody doing it once a year. EVLP is labour intensive. When we did it, we did the retrieval, we had the lung on the rig for maybe 4 or 6 hours, and then we did the transplant. And that was a long day. Is there room for commercial partnerships here? How do we make it all work? And there are various models. There's this sort of model, where you go to the donor hospital, it goes back to the transplant centre, and everybody works independently. Or there's this sort of model, which has been suggested in the United States, and I think has a lot of role in the lung. It doesn't have a role in the heart at all, but with the long ischemic times, particularly the ones that EVLP allow you to have, it has a lot of attraction. And if you think about that's where the UK transplant centres are, maybe we need 2 of those. Maybe we need 2 hubs. This would have the advantage that you'd have the perfusion done in a standard fashion by skilled technicians, not the registrar who gets dragged out of bed and has to read the book to work out how to do it. You could do proper trials of interventions because you'd have all the lungs, or all the lungs of a certain type, going through this particular process. You could link up with academic centres, you could link up with commercial partners. The problem is funding it. At the moment, the retrieval teams are funded by NHSBT, the transplant teams are funded by the local commissioners, NSD or NHS England. This would require some additional money. But I think for the lung, it's a very appealing step forward to let us get above that 6% utilisation in DCD and 20% in DBD and start eroding into those 30% of patients, just of the carefully selected ones we put on the waiting list. And finally, the other enticing thing about this is that if we move in the longer term future to either animal lungs, and the xenotransplant world is undergoing a revolution, although it's undergone revolutions before, or if we move to engineered lungs, and I was going to show you a picture, and I couldn't find the picture on my laptop, of a calf lung this size that had been completely recellularized and was functioning with ventilation and perfusion, having been initially decellularized. If we're going to use these really clever technologies, or the viral transfection of our DCD donors, or whatever it happens to be, then having it done centrally is going to be a sensible way of doing it. You would not want a pig farm by every transplant centre. You have them in a couple of strategically placed. You'd not want a tissue recellularization lab in every transplant centre. You put them centrally. So that might be the future. Thank you very much for listening to me.